Hyperthermia, I'm going to go through the objectives here pretty quickly. We're going to talk about heat-related terms. We'll talk about thermogenesis and what it is. We're also going to look at thermal gradient and then how we conserve or heat loss, the ways that we do that. And that's done through thermoregulation, basically. And then we're going to look at heat cramps, heat exhaustion, and heat stroke, and then some of the other factors that predispose us to having some of these conditions. So the definitions here, a normal body temperature, and I'm going to stick with the Fahrenheit, but just for the first one here, I'll also talk Celsius to give you kind of a range. So normal body temperature is 98.6 degrees Fahrenheit or 37 degrees Celsius. We know that that number is not always a guarantee. Common sense tells you that, you guys have taken temperatures before and the number is not 100% 98.6, but it kind of gives you a range. When I was in NP school, they actually told us that they were thinking about raising that number because basal metabolic rates have actually increased. So that 98.6 may not necessarily be the same number as it used to be. I don't know what that number would go to, but it's probably somewhere in the 99s. But that 37 degrees Celsius just kind of gives you a reference range of that would be an approximate normal, right? And then hyperthermia would be considered core body temperature of greater than 103 Fahrenheit. Hypothermia is considered a core body temperature of less than 95 degrees Fahrenheit. Another important factor with hypothermia is you lose your ability to shiver at that point. So if they're less than 95 degrees Fahrenheit, they don't have their ability to shiver, and we shiver to generate movement, which generates heat. So how do we regulate or create homeostasis? So our body's always wanting to be in balance with itself. So we have body temperature management, and we do that through thermogenesis, thermal gradient, and then heat loss and conservation, which is directed by the hypothalamus. So thermogenesis itself is heat generation. So this is what I'm talking about. We have to have the ability to generate heat, and we do that through shivering mechanisms, which are controlled by the autonomic nervous system, causing contraction of the muscles. When the muscles contract, we know that is shivering, and what it is trying to do is generate heat. And it does that through those cellular mechanisms that we are kind of talking about here, and that is known as thermogenesis. Keep in mind that kids, because we've been on a pediatric topic, it takes them longer to sweat than it would the adult, and they also sweat less. So they have larger surface to body or body to surface ratios in relation to what their normal body weight is. So they have a higher body temperature under normal conditions. So their normal body temperature is around 99.5, which would be about 37.5 degrees Celsius. Thermal gradient. Basically, the definition of thermal gradient is the distance between point A and point B and how much heat loss you have or how much heat gain you get. So heat flows from hot to cool all the time, okay? And this is an important concept. Heat will always go from hot to cool. So if you are in a warm environment, heat is going to go from the outside to you, right? So if you're outside working, digging a ditch, and your body temp is 98.6, but the outside temperature is 89 degrees with high humidity and the real feel is 100, then you are actually going to be taking on heat from the outside source. So we're going to gain heat in a warm environment. In a cool environment, remember, heat is always going to go from hot to cool. So the 98.6 that your body is higher than the outside temperature. We're going to lose heat in cool environments. So it would be really nice if these were reversed, but unfortunately, it's just not the way that we're made. So TA, which is the time of A versus the time of B and the distance that it travels, and that is what a thermal gradient is. Not that you need to really understand that, but when we're talking those words, that's what we mean. So how do we transfer it? Talking to a bunch of firefighters and EMS workers, so I probably don't have to talk a whole lot about heat transfer, but there's different ways: radiation, evaporation, convection, conduction, and then respiration. And we can evaporate heat at about 30%. So it's a fairly effective mechanism. And then radiation is at 65%. So those are the two biggest ways that we can actually have heat transfer, but we can have it all the way down to conduction at 2% when we are touching one object and we are able to conduct heat from one thing to the other. So it's all regulated by the hypothalamus, and this is a negative feedback system, and it is basically also known as the thermostat for the body. So the other way that we do this, in addition to the hypothalamus, is we have those peripheral blood vessels that cause vasoconstriction and vasodilation. And we really never think about it at that level. We just, oh my gosh, it's hot, I'm sweating, or I'm cold, I need to warm up, right? Well, this is all done through the hypothalamus, and it's all also done through the peripheral vessels causing vasoconstriction or vasodilation. So if we have heat and cold emergencies, basically what we're going to have is an imbalance of the heat generation or heat dissipation, which is going to result in damage to the organs. So we end up getting vessel dilation that helps to cool the body. If we get vessel constriction, that actually helps to warm the body. So your blood vessels are creating a lot of work for themselves to try to just keep you at a homeostatic temperature and something that is comfortable for you. When the temperature gets warm, obviously we're going to sweat, okay? And high humidity, if you have a high humidity situation, and last week I talked about, I was able to go to Socorro, New Mexico for a bomb course at one point. And they told us out in the desert, they said, you know, it's going to be over 100 degrees today, but it's a dry heat, high humidity, and you're not going to know that you're sweating. So you need to continually drink fluids. And it was true. I mean, it was hot. There's no doubt about it, but you didn't sweat until you got in air conditioning. And that is all because of the humidity and the ability for it to kind of do its thing based on some of those other meteorological type things. So if you're in that high heat, high humidity environment, it doesn't evaporate efficiently, so we can't cool off. And that happens when the humidity gets to be at 80% or higher. So when blood vessels constrict and keep the body warm, we're going to start shivering, but we're not able to do that if our core body temperature is less than 95 degrees. So here's basically how this works. We have heat loss, heat production, and that is all done through impaired thermoregulation and our inability to do that. Some of the predisposing factors that we may have is patient's age, their health, their medications, length or intensity of exposure, and then environmental factors. And if you think about it, this works for both heat and cold, right? If you're outside for a long period of time and it's cold, then you're going to have severe hypothermia. If you're outside and it's hot, then you may be running the risk of having a heat stroke. So strenuous exercise, firefighting, all of those things are predisposing us potentially to having some of these issues. And that is why I'm bringing this up at this time of the year. If we are on fires, we need to make sure that we have extra crews. We need to make sure that we are switching people out. We all have that mentality of, okay, well, another bottle and I'm going to be fine and just let me back in. And the reality is your incident commanders, your operations, whoever's overseeing that portion should really make sure that you have extra people and almost make people go to kind of cool themselves off so that we don't have an overheating situation in the summer months. So elderly, young, people that have diabetic issues, heart disease, if they've ever had prior heat-related illness, it predisposes them. So there are a lot of factors that go into it. Just let's keep an eye on each other and make sure that we're switching people out if it is a strenuous activity or a firefighting situation. So what is fever, right? We always talk about patients having fevers, et cetera. So what is it? Well, it's called pyrexia, and it's a normal response to an infection. And most of the time, these are pyrogens. It can be caused by a bunch of different things, either viral or bacterial type things, which are pyrogens. And then that resets the hypothalamic thermostat to a higher level. So it increases our basal metabolic rate to where our body is actually trying to burn these things off, if you can kind of think about it like that. So if the higher the environment is higher, it is less hospitable to that organism. The organism does not want to be there because it normally wants to be in a temperature of 98.6, for instance, and now it is in a temperature of 103. It is not going to like to be there very long, so hopefully it moves on out. And it is a vital physiologic function. We have to have good temperature management and regulation. So here's a patient case. This patient was actually taken into the emergency department at the University Hospital several years back. 80-year-old male, found down in a driveway in July. Outside temp was in the high 90s, possibly down for 6 to 8 hours, kind of found by a neighbor type thing. Nobody really knew exactly how long, but probably no longer than 6 to 8 hours. When EMS got there, the patient had decreased responsiveness, was found to be tachycardic. Arrival at the hospital revealed a temp of 105 degrees Fahrenheit. And the patient had a couple different things that we should mention here. They had second-degree burns on one side. They also had an intracerebral hemorrhage and ultimately ended up dying from this situation. So the takeaway here is don't get tunnel vision, okay? You respond and you find somebody down in their driveway and they're 80 years old. We're thinking initially, oh, okay, they just fell, right? There's a lot more to this situation. And clearly, even with gloved hands, when you go to load that patient up, you should be able to feel their skin temperature of 105 and immediately recognize that is not normal, okay? Yeah, you may not have good tools in the field to say it's 105, but you should at least be able to go, wow, they are hot, okay? Their skin is on fire. The other thing here is, why did they get second-degree burns on one side? Well, they're probably laying in the direct sun for 6 to 8 hours and the sun is beating down on them. And now they've got sunburn, they've got blistering, so they have second-degree burns. And that is the thought with this patient in particular, is it was directly related to the sun and not anything else that was inappropriate. And then the final thing here is the patient also had an intracerebral hemorrhage, which we may or may not be able to determine in the field. The only way we would know in the field, obviously, is maybe like some pupillary type stuff. Or if you see a big goose egg and your sample history reveals that the patient has, a history of taking anticoagulants, then it may lead you to believe that the patient might have a head bleed. But under normal conditions, we may not know this. So it's going to be picked up on in a CT scan in the hospital. And this patient had an intracerebral hemorrhage. So again, we don't know if the patient had a head bleed and then fell, or if the patient fell and ended up striking their head and having an intracerebral hemorrhage because of that. But the end result is, unfortunately, this elderly male did not survive this event. So please don't be tunnel visioned on these patients. Heat disorders, the continuum here, we have heat cramps, heat exhaustion, and heat stroke. So heat cramps, most of the time people will kind of say that it is just a very painful spasming type feeling of the skeletal muscles. And most of the time they are going to occur in the lower extremities. So the legs and then the abdomen are going to be the two primary things that the patients will complain about with regards to heat cramps. You can give these patients water or electrolytes, but you don't want to give them anything that has any type of sodium in it. Okay, so don't give them any type of sodium or salt, because where sodium goes, water follows, and we don't want to further reduce their volemic status. Heat exhaustion, the second one, the body is going to get more blood flow to the skin. So remember, we're trying to dissipate that heat or get rid of it. So we end up getting vasodilation, and all of that heat is going to end up going to the skin. So there's more blood flow to the skin. So there is less going to the vital organs. If all the blood flow is going to the skin, then our heart, our brain, and our kidneys are not getting the same amount of blood flow that they should be getting. And that is where heat exhaustion actually starts to come in, and it begins to look like a stroke-like state, or a shock-like state, I should say. And then ultimately, if we do not correct that, it is going to lead to heat stroke. So heat stroke, the symptoms stop because basically the body is overwhelmed. It is not able to keep up with getting rid of the heat and dissipating like we were hoping it would. So they have now low body fluids, they have reduced or no sweating. And then, as we kind of talked about before, the brain and the other vital organs just aren't getting the blood flow. So they start to fail. And the kidneys and their heart are going to be two of the primary ones that are going to end up failing first. And sometimes heat stroke will progress, obviously, all the way to death because of the organ failure. So morbidity and mortality. So looking at this and pulling some of this information, average deaths of 751 per year over a 14-year period. So what I'm trying to say here is maybe year one there were 700, and year two there were 800. Over that 2-year period, it's 751 on average. So the average death rate in the United States is 751 people per year times 14 years. Okay, so increased during heat waves, which makes sense, but there are 3 states that really kind of take the cake here: Arizona, California, and Texas. Those 3 states, if you add their population together, they end up making up 23% of the United States population. But when we're talking about heat-related morbidity and mortality, they're responsible for 70% of all the heat-related deaths. So they make up a quarter, and they're responsible for 3/4, basically, of heat-related deaths. So we got to do better about recognizing this and getting people into a cooler environment. Some of the predisposing factors are going to be extremes of age, and this is because of decreased ability to regulate temperature. Other things that may cause this are dehydration, if they're diabetic, heart disease, skin disease, any type of burn that goes along with it. So in our case study, that gentleman obviously is in worse shape because not only does he have his heat issue, but he also has the 2nd-degree burns to go along with that. Endocrine, neurologic, delirium tremens, or your alcohol or withdrawal type situations, which oftentimes goes with homeless population. So they're at a higher risk even so. And then fever, as we've already talked about before. Some of the medications that can predispose, I'm not going to go through all of them, but these are all things that you guys have seen for sure in the field. Every one of us that's been doing this for longer than probably a month has seen a patient on a beta blocker, a diuretic, or something like that. So all these medications can certainly predispose them to other factors. Environmental factors: temperatures above 95 degrees Fahrenheit, the radiation will cease at that point. So then evaporation is the only means of heat loss. So you're more susceptible at greater than 95 degrees to have a heat issue. And it's not because it's just hotter, right? It's because it actually changes the ability to get rid of the heat internally. Humidity at 100%, the evaporation of sweat ceases. And then the absence of wind. We actually want wind to be blowing across the skin to help cool. And I know that that sounds very elementary and very basic, but physiologically, it also helps tremendously. Regulation of body temperature, we talked about the hypothalamus being the organ that helps to do that, and we get peripheral vasodilation. And when we have that happen, when we dilate out, we get increased evaporation and convection. So that is how we're able to dissipate that heat and cool our bodies down. And then we get renal vasoconstriction, so the blood vessels in the kidneys actually start to constrict to increase all of that blood flow to the skin to help get rid of the heat. When we do that, now we have a resultant decreased or lowered urinary output. So, you know, everybody knows this. I could have talked to every EMT and paramedic listening right now and said, what happens in a heat situation? And everybody would have been able to say, okay, well, they sweat. Okay, well, what about urinary output? Oh, it reduces. But I don't know that a lot of people would understand why that is actually occurring. And it's all because of the vessel vasodilation in the periphery and vasoconstriction in the core system. Excessive heat exposure, basically what happens here is heat generation is greater than heat dissipation. So your body is taking on heat quicker than it can get rid of it. So we need to try to tilt that scale if we're able to do that. And this is just another example of if I have decreased heat loss and increased heat production, and that's all done through impaired thermoregulation. All right, so let's look at the final kind of portion here, which is heat cramps, heat exhaustion, and then heat stroke, and then we'll wrap it up for the day. So heat cramps, we're talking about sweating from an elevated temperature. You end up losing that sodium or salt, and the loss of sodium causes muscle cramping. Remember, that is occurring in the lower extremities and in the abdomen. It is where is most commonly reported. Is typically not a life-threatening thing, but it can be very painful. If you've ever had any of these electrolyte abnormalities, your legs start hurting and just aching. It can be a very painful thing. So it can progress to a more serious illness if the imbalance is not corrected. So we need to try to correct it as quickly as we can, and we do that through either water or electrolytes, but don't give them any more sodium containing fluids. So heat cramps. So signs and symptoms here, muscle cramping, you can kind of see grabbing his calf there, weakness, vital signs are normal. The temperature is normal to mildly elevated, and they have a normal mental status. Their skin may be warm and moist, but it is not going to be hot at this particular time. The treatment, get them into a cool place, rehydrate with oral electrolyte solutions, and then you can give IV hydration if necessary. We just don't want to give them any type, and I know it's normal saline, so there is 0.9%. That would be an appropriate amount of sodium to give this patient. We just don't want to give them anything that is containing sodium through an oral mechanism. Heat exhaustion. So this is the most common heat-related illness seen by EMS, and that makes sense. Heat cramps, people experience it more frequently. We just don't get called for it. They end up going in, they sit in the air conditioning, they cool off, they get something to drink, they don't call 911. Heat exhaustion, because it's progressing kind of that next step, the family gets concerned, they end up calling us to see what we need to do. So it's the most frequent one. The etiology is acute heat injury with hyperthermia. The patient is going to have basically a severe marked dehydration, sweating, and loss of sodium, and they can lose 1 to 2 liters of fluid an hour. And that is going to result in them having a decrease in their cardiac output. Basically, they'll be able to keep up with it for a little bit of time, and then the body is going to start shutting itself down. So they're going to have myalgias, which is like muscle cramping or muscle pain, nausea, vomiting to go along with that. And then some of your CNS symptoms they may or may not have, as far as headache, irritability, and maybe dizziness. When we take their temp, if we have the ability to do that, you're going to feel that their skin is actually warm. And it may also be moist because their body is trying to dissipate that heat still with sweating. So by definition, it should be over 100 degrees Fahrenheit. They're going to have tachycardia and then orthostatic vital signs. Not that we would do that, but if you did, then they're going to have a reduction from a seated to a standing position. What do we do for it? Get them out of the hot environment. Common sense has to prevail, right? Take their clothing. If you're able to do that, and protect modesty. Fan the patient, put them in a supine position. You can still give these patients oral hydration as long as they're alert oriented and can protect their own airway. And then IV hydration is necessary. Consider 1 or more serious causes if the symptoms persist. So heat exhaustion obviously can progress to heat stroke, so we need to try to break that chain. The final one here is heat stroke. So what happens in heat stroke is an abnormal temperature, a core body temperature basically. And we kind of say that this is classic versus exertional heat stroke. So classic heat stroke, usually the patients are going to have some type of a chronic illness and they have lost their ability to thermoregulate. So maybe they have a tumor of their hypothalamus that is not able to keep up and regulate temperature anymore. So most of the time related to an illness, but the end result remains the same. Exertional heat stroke is probably where most of us will come into play. Firefighting activities, working out, those types of things. Most of them are going to be healthy individuals. The skin may actually still be moist secondary to exertional sweating. So don't let that misconception of heat stroke has to not have perspiration. They still can sweat, even though they are having a heat stroke condition, but it is probably going to be a reduced or minimal amount of sweating just based on everything that is going on between the ability to dissipate and conserve energy. So Covington differentiation between stroke and exhaustion. I'm not sure exactly when you put that into the chat. I think I just answered that question. If I did not, please let me know and I will re-answer that for you guys. And I'll keep an eye on you guys replying to that. So elevated external temperatures. It's probably going to be a little bit warmer. Even than the 100 degrees, we're probably going to see things that are over 105 for your individuals that are suffering from a heat stroke. It is a true medical emergency, and this does carry a fairly high mortality rate, 10 to 70%. I know that's a wide range, but even at 10% dying from heat stroke, we got to do better about recognizing this when it is a heat cramp and a heat exhaustion so that we can try to fix the numbers here with heat stroke. If that gets over 105, then that is considered what is known as uncompensated hyperthermia. Their body's basically not able to keep up, and now their temperature is just raising. So what happens is we get cellular death, and that cellular death occurs in the brain, the kidney, and the liver. Your body is going to end up shutting down, and we have multiple organ failure because the body temperature just remains too high. How do they look? Well, they'll have an altered mental status if they have heat stroke, and that may have a different appearance, and they may be a little confused, or they may be like way confused. It just depends on the situation and what their temperature is, but they can hallucinate, have confusion, coma, seizures. So in addition to the findings of those found in heat exhaustion, and remember what those signs and symptoms were, your heat stroke patient will have these in addition to that. So physical exam continued here, their vital signs, they're going to have an increased heart rate, widened pulse pressure, hypotension, especially diastolic hypotension. So their filling pressure is not going to be able to keep up. We're going to notice that they are extremely hyperthermic, over 105, 106 degrees Fahrenheit, and then the tachypnea to go along with that. So they're trying to cool themselves off, and honestly, what they're doing is making more heat. So their temperature is going to continue to rise. So the skin is going to range from warm and dry and diaphoretic. With exertional heat stroke. So key takeaway there, it can still have a little bit of diaphoresis associated with that. And that's actually a good thing because that is our cooling mechanism. So don't just rule it out because they still have a little bit of sweating. The coagulation disorders, bloody stool and hemoptysis. So you may end up seeing, if they're not having the ability to coagulate appropriately, that they end up losing stool in their bowel. So they'll have bloody stool or hemoptysis, which is just coughing up blood. And then from the GI system or the GU system, hematuria. So they start actually peeing out blood, and then ultimately they end up with multi-organ system failure. So this is pretty simple, right? Not that they're going to do well, but the treatment, you got to get them out of the environment, cool them down, drive with the windows open or the AC on. If you're in a normal ambulance, the AC is probably not working. So the windows being down might be the best route. But if you have air conditioning available and it's working good for you, then put the air conditioning on for the patient. Try to get their clothing off and then initiate a rapid active evaporative cooling. And we can do this by covering the patient in a moist sheet, right? You don't want them to be cold, but try to cool them off if you can. And then fanning or misting will help. And then you can ultimately put some cold packs, break your cold packs, and put it into like the axilla under the armpits there, into the groin area, to try to cool them off if you can. Where do we want our temperature to get? So it's kind of like dealing with a patient's blood pressure, right? We don't necessarily want to drop it way back down. So the target temperature should be around 102-ish. And then we should work to decrease by 0.2 degrees Celsius per minute. We don't have to necessarily worry about that. My point is, I don't want you guys like making these patients hypothermic, right? Don't take them from a hyperthermic state and then dump them into an ice bath in the gym and leave them in there for a half an hour. It's going to cool them off way too quickly, and that can cause problems too. So get them into a cooler environment and start reducing their temperature, but we want to do it in a controlled manner. Frequently reassess their temperature and then avoid overcooling, as I've already mentioned, because shivering is going to cause an opposite effect. Shivering is going to make the patient start to shiver and generate heat. So heat stroke here, administer oxygen, rehydrate them, put a normal saline IV in or lactated ringers, whatever you have available to you. put them on a monitor, and then avoid trying to give some of these medications. Vasopressors, your anticholinergics, and then antipyretic medications like Tylenol and aspirin should be avoided in these situations. It is a different mechanism. So don't give these medicines because that's not why they have an increased temp. And then we should be thinking about our differential diagnoses. So is it malignant hyperthermia? Have they had any type of surgery and they've been under anesthesia? That will make them malignant hyperthermic, potentially, not always. Hypothalamic effects, septic shock. Did they ingest some kind of poison? Do they have an encephalitis? Do they have diabetic ketoacidosis? So again, back to the guy that fell and was found down in his driveway. Don't get tunnel vision, okay? Rule out all of your different factors. And I say this, and it's hard when you're new because you want to be a good provider at your job and walk into the ER and tell them exactly what's going on. You know, I'm at the point I can walk into the ER and I'm just comfortable enough saying, I have no idea what this is, but I know what it's not. I know that it's not their sugar because I checked their sugar, right? Or I gave them D50. I know that it's not an overdose because we looked at their pupils or we gave them Narcan. So rule out those things that we can rule out, and then make sure that you keep in mind the ones that you can't rule out, which some of them are on the screen, obviously.